She is 3 weeks out from her arthroscopic rotator cuff repair, specifically repairing the supraspinatus tendon, and we are going to start some joint mobilizations. We are going to use both scapular and glenohumeral mobilizations to increase her range of motion in the shoulder joint, as well as prevent any adhesions or contractures that could occur after surgery with scar formation. So I'm going to start by demonstrating the scapular mobilizations. We're going to do superior to inferior as well as medial to lateral. This is going to be especially important in the 3 to 5 week range when we're seeing her to help with that range of motion that she lacks in the shoulder. We are also going to progress it to 9 to 11 weeks, and then if she still needs it, if she's still having trouble gaining that range of motion, we could progress it to the 15 to 17 week and keep using it in our treatment. So first thing I'm going to do to demonstrate the scapular mobs is just get consent from the patient. So it's okay if I bring your arm up and rest it. So I'm going to instruct her to relax her arm onto my arm here. And then I'm going to find the inferior border of the scapula by palpating, as well as the superior border. And I'm going to use this broad contact here. And I am going to mobilize it superior, as well as inferior, and medial to lateral as the patient is relaxing on my arm. And then as it gets further in the treatment, there's evidence that adding a rotational component will be helpful. So I could go into superior and do that, inferior and do that, as well as medial and lateral. And then I'm going to instruct the patient to turn onto her back so that we can start the glenohumeral mobilizations. So we're going to position her in as much of the range that she has available right now. So she has about 45 degrees of abduction and 35 degrees of external rotation. I'm going to ask her to move a little bit closer to the edge. I want to make sure that I'm not getting table end feel when I do this mobilization. So I'm going from anterior to posterior. I'm going to palpate the shoulder joint, and then I'm going to make sure I'm out laterally enough here. And I'm going to apply a grade 1 to 2 mob, whichever one is tolerated by the patient, onto that glenohumeral joint. And then we are going to progress this throughout the treatment by increasing with her as she gains range of motion. So as she gets more abduction, more external rotation, we'll end up out here at the end of treatment. And if she still needs help to gain that last bit of range of motion, we'll keep doing higher grades of this glenohumeral mobilization in this position.